It's an interesting setting. I feel like it's, hi, I'm your host, Robert Earley. This is Good Morning, Texas. You know, that's always so cheesy, you know. Hi, today we're going to learn about, we have a luxury because as Laura mentioned, we just don't have the ability to come into work and think that that's a vacuum of an environment. We have to deal with the changing nature of the industry we work in. We do not have the ability to complain about the changing nature of it. You do, you can, but it gets you nowhere. And I think that JPS has advanced so much as an organization that we now need to think about what and where did we come from and where are we going. And that is a role that every one of you play in here. Every one of you. So what we're going to do today is discuss a variety of those things. We're going to talk a little bit about where we've come, what started the financial reimbursement model. Where did that come from in the history of the United States? We're going to talk about where are we today at JPS and where are we going and what does the future look like? And to help with that, we've brought in a guest speaker that I have great admiration for. And although I know this gentleman well, I'd like to read you his introduction. Mike Spivey was a leading high school recruit in the state of California. He was a lacrosse player. He played lacrosse in California. He went on to play 4 years professionally in Europe before going on to college in the United States. He's the author of 8 books and 2 movie screenplays. Where did this come from? You wrote it. You wrote, because this is bogus. This is not.
If you're going to do an introduction, I want it to be a good one.
That's not even true. There's nothing on here that's true. You're not from California. You never played lacrosse. And I don't think you've written 8 books and 2 screenplays.
Well, yeah, but other than that, it's perfectly accurate.
Our guest today is a bogus speaker who has no, actually, you know, the format today is sort of you and I having some dialogue.
Right.
So let's talk about it a second because Mike is incredibly talented. But let me ask you a few questions so we don't do the stock standard introduction. 4 years ago, you went back and completed your PhD, which I think is so powerful from a learning standpoint and for the perseverance that took. Tell us about that process. Tell us where you teach and the classes that you currently teach.
Sure. So I am a professor at the University of Maryland, the Department of Government and Politics. I specialize on issues surrounding the courts. I do a lot on the Supreme Court. I actually went back to school not 4 years ago. I got my degree in 2015. I went back to school about 15 years ago, and it took me 11 years to get a PhD. It took me 5 years to write a dissertation. It felt like it still feels like it was a book, and it's long enough to be a book, and in fact, it may be published next year. So maybe one of those things may be sort of true. For me, though, it may sound a little strange, it was fun. I believe in lifelong learning. I believe in learning something new every day. It's the way you stay young, is to always learn something. It also tends to make you better at what you do if you learn something every day. So I think all of your folks are lifelong learners, and I think that's part of the culture here at JPS, and that's part of the reason you're here today, and I believe in that very strongly.
You got a law degree.
Yep.
Talented
Don't
lawyer.
hold that against me. I'm from Washington, inside the Beltway. That's 2 strikes.
2 strikes. And you work for the former governor of Illinois.
I did. I was a senior
So you're
assistant.
out of the game. That's 3 strikes.
Yeah.
Move on.
Yeah.
So you've had an interesting career that's taken you from public policy to being one of the leaders in the nation on healthcare reimbursement and healthcare delivery. Did you see your path going this way when you?
No, you forgot to mention that I have a master's degree in divinity.
Exactly.
Yeah, I mean, that's where I started.
Yeah. There you go.
I'm all right. Go divinity. Don't hear that very often, do you?
Well, what you don't hear is go divinity, and what you don't hear is I got a divinity degree and then I went to law school. That is really the disconnect that we're not hearing.
Yeah.
So.
Yeah, so I did that. I then got a master's degree in public policy studies, and that led to the job in government. And I worked as a senior assistant to a governor for 5 years, and I saw the messy process of making policy up close and personal. And then I, through that, discovered that having a law degree and having those skills could make one much better in doing that job. So I went back, I went to law school. Didn't plan on this career. I went to law school intending to go to work for the Senate Judiciary Committee, and in fact had a job offer for them to go work when I graduated from law school. Unfortunately, my law school debt, their salary didn't mesh very well, and so that didn't work. I went to work for a firm, and joined that firm thinking I would do litigation. I was going to go be the next Perry Mason, and I did litigation for a year, absolutely detested it, and main reason when you're a first-year associate doing litigation, you never see a courtroom. You just see rooms with no windows and lots of boxes of documents, and I decided that was not for me. And as fate would have it, the person who worked on healthcare issues left and went to Capitol Hill to work on Clinton Care, the original Clinton Reform Act in the early 90s. They knew I had worked in government. They came to me and said, will you take this spot? Are you interested in doing that? And I did, and 25, 30 years later now, still doing it. Pretty good career.
I'm impressed with Mike Spivey for his academic background. I'm impressed with Mike Spivey for the fact that he is a talented teacher. But I think actually the thing that impressed me the most about Mike Spivey is the way he talks about his son and the way he talks about his wife. He's a dedicated family man, which I appreciate, and he's a really good guy. So I think we're going to learn something here today, and I think we're going to get some real value from the expertise of a national leader in trying to figure out answers that don't come easily. And even when you deduce the answer, that answer can change from day to day. And so that's what we're going to go through. If you don't mind, Mike, I think we start from basics, and that is, why do we even have the institutions that we have today? Where has healthcare come from its beginning stages? When did hospitals come about? What was the purpose of them? Give us a little bit of history, because we are all subjects of our own history.
Yep. So the first hospital opened in Philadelphia in 1873 or thereabouts. Up until that time, healthcare was delivered by individual doctors going to see individual patients at their houses. And with the development of medicine, and a lot of these developments happened during the Civil War, the invention or the discovery or creation of anesthesia, making surgery possible, a different model was needed and a different model developed, and so we brought the patients to the doctors and to those services. And that was pretty much the tradition and the approach for the next 100 years or so. The number of hospitals grew steadily every year for the next 98 years, peaking in 1971. And since 1971, there's actually been a decline in facilities. The number of facilities is about 20% less today than it was in 1971. And part of that is because, again, of the changing nature of medicine. Just one example. Today, a lot of surgery that would have taken 3 days and required you to stay in the hospital for a longer period of time can be done on an outpatient basis. Some of that can be done in a doctor's office today. That was unthinkable in 1971. And so, again, the delivery of medicine has changed and shifted and evolved as our technology has changed with it. We haven't always evolved, however, in terms of the way and how and where we go deliver that medicine. Our facilities, as this quote suggests, are really 20th century facilities, post-World War II kinds of facilities that haven't yet caught up with the technology that we have today.
Tell us a little bit about the other aspects, not just the facility. Tell us about how we have evolved from the payment of the procedure and the care you're going to get. What role the United States has, because we may find ourselves a little bit different than other countries. Give us a little bit of walking history about the evolution of payment and how things started and where we are today.
So for the first 140 years ago, there was no payment except by the patient. Everything was fee for service, and it was whatever the patient and the doctor agreed to. If that was money or if that was a chicken, it was the patient doing the paying. And insurance really came about in the early 20th century, and it was restricted to a very small number of people, the elite, those that had money and could afford to pay premiums. Most everyone else could not. It really took off in World War II and thereafter, and it took off as a bit of a fluke of the policy process. During World War II, the United States imposed wage and price controls. Go see pictures now of women working in factories, and the men are off at war, and there's a shortage of labor, and the government had said, because we need material to build the war machines, we're going to limit what you can charge and what can be paid for these other things. Companies wanted workers. How do they attract workers? Because they can't pay them more. Well, they struck upon the idea, we'll give them benefits. We'll create pensions. We'll create healthcare insurance. And so healthcare insurance really took off and really was the product of the fact that we were involved in World War II, and then expanded for the next 20 years. It became one of the favorite benefits that companies could offer. Government at this point is not terribly involved in healthcare. It tried to be. There were 4 attempts to pass some kind of national health insurance, beginning with FDR. Never successful. Did not become successful until 1965, when the federal government then implemented Medicare for the elderly. It was part of Johnson's war on poverty. Medicaid, one of your biggest payers, was created at the same time. It was really an afterthought. It was not, the intent of the legislation at the time was not to cover the indigent, but rather to just cover the elderly. But they looked around and saw the issue of access and the need that was there, and so that got, at the last moment, rolled into that legislation, and that's when the federal government involvement really in healthcare really took off. So
tell us, I guess, how it relates to us in the world that we live in today, trying to figure out a payment structure. I mean, obviously we have a large population here that doesn't have the financial means to pay for their health care delivery. Tell us where we are more in a setting of today in looking at reimbursement dollars. And I think what we hope this LDI will equip you to do is not only become knowledgeable about what's going on, but be able to go to a healthcare cocktail party and be very intelligent as you talk and say, well, I know about dish payments and disrupt dollars and UC. And there are a lot of terms that we throw around that I don't know that we oftentimes know exactly what that means. So go through, if you don't mind, where we are today and what some of those reimbursement dollars are and how that's kind of evolved.
Sure. And you mentioned a few acronyms. The key to being successful at a cocktail party is just to throw around acronyms that people don't know what they mean. So only you know. So I'll try to use some of those, but I'll tell you what they mean. So in terms of JPS, you mostly deal with the government. You don't have a large privately insured population here, and so you're getting paid by the state or federal government for the services that you're providing to patients. You can think of, I'll put Medicare to the side, you get some Medicare, but I'm going to focus more on indigent patients, and you really have 3 payment streams here. First, you have Medicaid fee-for-service or capitated payments for services provided. So a Medicaid patient comes into you, you do something for them, you bill Medicaid. If they're covered by a managed care plan, you bill that plan, you get paid some kind of negotiated fee. They've gotten a capitated fee, but either way, you're paid because you did something, you provide a service. So that's revenue stream number one. Then revenue stream number two, which you mentioned, is DSH, disproportionate share hospital payments. And under federal law, 42 U.S.C. section 1396 R4, to be specific.
That's why we were paying him to come today. He knows that stuff.
Throw that around at a cocktail party.
He will never be invited back again.
So under that section of the federal code, states are required to make additional payments to those hospitals that serve a disproportionate number of low-income patients. JPS is a DSH hospital. In fact, JPS is one of the dishiest of the DSH hospitals that are there. Your ratio, as calculated under that statute, is one of the highest in the state of Texas.
Put that on our monitor. We're the dishiest of the dish.
And so when these patients come in and you provide a service to them, and they either are Medicaid eligible or they are uninsured, you capture the cost of those services. It goes into a report that goes to Austin, and you get paid for it. It's not based on what precisely you did for that patient. It's based upon the cost of what you did minus whatever Medicaid happened to pay for that service. So that's bucket number two, very important one for JPS. And then finally, bucket number three are UC payments, uncompensated care payments. Those are payments that are made pursuant to a section 1115 waiver. I guess I should say what an 1115 waiver is, right? So under federal law, there are all these requirements about how a state has to operate its Medicaid program. What kind of services have to be provided, where those services are available, how those services get paid for, tons and tons of regulations. There is a section of the U.S. Code in Chapter 42, which I mentioned, Section 1115. That Section 1115 says the following: the Secretary of Health and Human Services may waive any requirement of the Medicaid statute if the Secretary determines that the waiver of that requirement is in the best interest of the Medicaid program. Texas sought a waiver under that section to waive various requirements. I won't get into all the particulars. Some of them have to do with the delivery of managed care, where that managed care is delivered, state wideness rules regarding consistency of reimbursement across the state. But the other thing it did is it waived certain caps in terms of Medicaid reimbursement and created this pool of money to reimburse you for the uninsured patients that you see. So like DSH, for those patients, you're not billing for the service that provided to that patient. You're aggregating all those costs up, and then you're billing the state Medicaid agencies for them, and that comes back to JPS as a lump sum payment. DSH, you see, terribly important to JPS. You wouldn't continue to exist without those payment streams.
For those of you taking notes, you've already gotten an A today, so thank you. And Terry, for being the only one that sat on the front row. You get an A. Way to go. Very, very impressed and proud of you. The rest of you churchgoers sitting in back pews, very typical. I get it. Today is not about politics, the people. We are not here to give you any of a political viewpoint of what one thinks of Mr. Trump or Mr. Obama or the United States Congress or anything else. However, we do need to put that in context of the regulations and the guidelines that are placed upon us. So in no way should one interpret anything that's being said although I did find it interesting that you mentioned the wording for the Secretary of Health and Human Services. I know that a tweet just went out, and he's been fired too. So he's no longer there. But these are not political statements in any way. What I do want to, though, talk about is tell us about the Affordable Health Care Act and what it means to us, and the political debate about the beginnings of the Affordable Health Care Act and why this nation thought it needed it, and why maybe this nation now debates as to why it doesn't need it.
Okay, so let me back up and let me start again in 1965 with Medicare and Medicaid, and then we'll flash forward to 1992 and health reform, and then the Affordable Care Act. So Medicare, American Medical Association, AHA wasn't thrilled. They opposed the implementation of these federal government programs. They were worried that those were the first step to socialism and government control of medicine. Nonetheless, those programs passed, and they became wildly successful very quickly. They worked as they were intended, with one exception. They cost a heck of a lot more money than the Office of Management and Budget, wasn't called that then, but the OMB said they were going to cost by a factor of about 10 within the first 10 years. And so suddenly we have more people covered, but the cost of health care shoots up dramatically. The inflation rate for health care versus the CPI, the Consumer Price Index, during this whole period, from a couple of years after the implementation until now, has run at best around 1.5% of CPI, and in some years it's run 3 to 4%. In the early years it ran slightly higher than that. So the costs are accelerating rapidly, and now 30 years later we have very expensive programs, but we still have a great lack of coverage. 50 million people in 2000 are still uncovered under these programs. How are we paying for them? We're paying for them through the back door. We're paying for them through higher private insurance rates. It's not as though those folks were free when they come to you, right? So someone has to pay. So how are we paying? We're charging some amount of that, not specifically, doesn't appear on your bill when you leave a hospital, but some of that is being passed through private insurance companies to subsidize that cost, and then through the DISH and the UC pools that I talked about earlier. And to give you a sense of this, so DISH was passed in 1987. I was, that was beginning of my working in law. I was there for the creation, helped to pass that statute, and then I helped to make it a success. And in the first year, we spent $150 million on DISH payments in 1988. 2 years later, we were spending $16 billion on DISH, to give you a sense of how much uncompensated care was out there. And so policymakers looked around and said, we got two big problems. We've got rapidly escalating costs, and we still got too many people uninsured. So what do we do about it? And the first attempt to do something about that was in 1992 with the Clinton Reform Plan, and this very complicated private market-based system, creating a whole slew of new agencies to regulate the insurance market. You probably remember how that turned out. Did not even get a hearing in the House Ways and Means Committee, for example. So that goes away, and then there's a renewed push. There's some incremental changes during that period. CHIP is implemented, the Child Health Insurance Program, another acronym, make a note, CHIP, throw that around at dinner parties, is passed in the late 80s. That expands coverage for kids, but we don't do anything about adults. And Obama is elected. And Obama decides that one of his first priorities is going to be trying to expand coverage, healthcare insurance coverage in the country. And they decide to base their system on a model developed by the Conservative Heritage Institute and as implemented by the state of Massachusetts under Governor Romney. So in some ways, this should never have been called Obamacare. It should have been called Romney Care. They take the Massachusetts model. The Massachusetts model and Obamacare are based upon, think of it as a three-legged stool. There are three pieces of this that are designed to both control costs and expand access to care. Leg number one is to regulate insurance coverage, insurance policies. There are all these policies out there that are not standardized. People will have trouble figuring out which policy to buy. It's hard to compare two different kinds of policies. There are crappy policies out there. We used to, showing my age, but we used to refer to those as art link letter policies. The old art link.
How old are
Old,
you?
I'm old, yeah, so old. He used to have a TV show, and he would say, for $1 a day, you can have hospital coverage. Of course, what he didn't say was they only paid $25 a day for your hospitalization, and you had to cover the rest. And so the first prong here, the first step, first leg on the stool, is to regulate that, standardize the policies, and make sure there are minimum coverage standards for all these policies. Leg number two on the stool is to expand private health insurance coverage. How do we get insurance companies to go cover more people? And how do we make that coverage affordable? Well, we create these exchanges, either run by the state or run by the federal government if the state doesn't want to create an exchange, and we give them money. We create subsidies to patients who buy policies through that. We're going to have tiers of policies, gold, silver, bronze. They're going to cover different things. We're going to peg the subsidy to the type of the policy and to the income of the individual buying that policy. And the theory is if we do enough of that, we can assist people in buying private insurance. So leg number two. Leg number three is the government piece of this. We're going to expand Medicaid coverage. And how are we going to do that? Again, we're going to spend a bunch of federal money. We're going to give states initially 100% of the cost of expanding their Medicaid programs to cover more people. Might shock you, I'll use Alabama as an example here, might shock you to learn that in Alabama, a adult there does not qualify for Medicaid if they make more than 25% of the federal poverty level. Amazing, isn't it? And so the whole notion here is that we're going to put minimum coverage levels on the state. You'll have to cover 100% or 125% of the federal poverty level, but don't worry, the federal government will pay you the difference between that cost and what you were doing before, different than the matching rate that you get for the rest of your Medicaid population. It'll ratchet down after a few years, but it's going to be set at a floor of 90%. So those three things were designed and intended to greatly expand the number of people covered. And then what about, to use the inside the beltway term, bending the cost curve? What do we do about bringing down costs? Well, the notion here is that through greater regulation of government programs, as well as through the competition that's going to come from these insurance plans, that the cost of insurance and therefore the cost of health care will decline. Dubious as to whether that's really worked or not, but that was the theory here.
I think what we'll do now, you know the cards that you've got for you, we're going to start, if you have questions, we're going to try to get to some of those, and we're going to intersperse those through. So part of your fee for coming here is to get a series of questions that are incredibly complicated that will make it very difficult. And what we're going to do to make it even harder for you is we're going to put the question up on these screens to see if you can really answer it. So
cool.
Here you go. So question number one, let's see if we can have that up. Okay, there you go. What do you think about that?
That one's really easy.
Okay, go to question number two.
Oh, that's good. That's all I got to say? It's really easy. Okay. How will that transition take place? No, not going to happen. Next question. Now, here's the problem. We have basically two ways of paying for health care, and they're both bad. The first way is fee for service. You pay based upon doing a thing, providing a service. You bill for that service. We have no uniformity across that. In fact, we don't even have transparency as to those things. I mean, if you need, let's say you need a simple kind of surgery, do you pick up the phone and call various hospitals and say, what's your price today for this operation? No, you don't know what it is. Your insurance company knows what it is. They negotiate fees. You don't know what they negotiate. You don't know how much of a discount they're getting against that. This is an opaque system that rewards overutilization and oversupply of services. Why? You do more, you get paid more. It's not a great way of paying for health care. What's the alternative? Capitation. Now we'll give an insurance company or a plan an amount per patient, and they have to manage that patient, coordinate their care, make sure it's all efficient. They're going to go out and either subcapitate, pay you as a provider a set amount for all the patients that are enrolled that come to your facility, or they're going to have a fee-for-service rate that's paid out of their capitation. But now we have the opposite problem, a problem of underutilization, of underpayment. Why? Because the less the plan pays out, the more they get to keep in the money. And I think about these, when I think about these payment plans, these payment methodologies, I think of them in terms of building a house. So imagine you're building a house and you hire an electrician. And you say to the electrician, I will pay you $10 for every outlet that you put in my house. Go to it. Guess how many outlets you're going to have in your house? They're going to be everywhere, including the closets. Now you tell the electrician, tell you what, I'll just pay you a set amount plus a cost base for what you're doing. Now guess how many outlets you have in your house? You can't find one, right? Differing incentives created by the differing payment methodologies, and it's very difficult to create the right incentive. So how do we do that? We pay for performance, buzzword inside the Beltway. We pay for outcomes. Now we're not going to pay for a service. We're not just going to pay you a capitation amount, which you can try to go pocket and keep from the provider. We're going to pay you for what actually happens to that patient. Great idea. Terrific theory. Only one little bitty small problem. How do you do that? How do we figure out what the outcome is supposed to be? What's our baseline of comparison? What if you don't perform? What if the outcome is not good? Do you not get paid if you provide a bunch of services? I don't know, I'm just guessing. The doctors in the room can probably help me out on this one. But I imagine you don't want to be paid, or you still want to be paid even if something happens to your patient. And so we haven't figured out the answer to that question. It sounds great in theory. It's a wonderful buzz term. It's where we're trying to go, but we haven't yet figured out how to do it. So in terms of that transition, not to the transition point yet.
I think that it's critical that all of us here in this LDI begin to figure out the world that we live in and the challenges that we live in here. And it's hard, and these answers aren't easy. So what you're answering from the attitudes in Washington or what we're doing here locally, because Texas is a state that has not expanded, and so it is a challenge, and it's a challenge for who's coming through our front doors. And oftentimes we are held to the whim and the fancy of elected officials who don't work in this facility. And sometimes it's easier to create a policy, but you don't have to deal with the people that are affected by that policy. And that's a really hard thing. Jared, we have the next question.
Let me say one more thing about that one, if I might, because your comment prompted that. And that your comment goes to this issue of disconnect often between the politics and the policy that we're talking about. And there often is a real disconnect there. I'll tell you one story from early in my career. I went up to Capitol Hill to talk to a congressman about a bill, and he was on one of the key committees. He was on Energy and Commerce, which had oversight over the Medicaid program. And I walk in, and I have my whole spiel laid out, and I start with my little speech, and I get about, I don't know, maybe 90 seconds into it, and he stops me, and he had kind of a southern accent, and he goes, so tell me, you're talking about Medicaid, right? And I go, yep. He goes, so Medicaid, is that the one for the old people or the poor people? Now, this is a guy on the committee which oversees this program. Wouldn't you think you would know the answer to that question? And so when we asked of these folks that they understand what the delivery of medicine is really about, how it occurs, and how it should be paid for, I would suggest to you there's a fairly large disconnect between the knowledge base that's there and the knowledge base that you in this room have. And one of our challenges is somehow to get your knowledge from this room to those other venues. The final thing in terms of that transition, and transition in the big arena is often difficult because the politics gets in the way of the policy. We talked about those two payment methodologies. There are vested interests who do not want to see those methods change. There are folks who are very happy with fee-for-service medicine because they know what their income is going to be, and they have the ability to affect their income then. In fact, we've seen this when CMS has attempted to restrict payments for under Medicare for certain services. Guess what they discovered? There were more services provided. You made up in volume what you lost in the rate for that service. So the politics of this is very difficult. It may be that in terms of that kind of transition, we need to be thinking about that transition at the local level. What can we do here to find partners to create that kind of payment model?
Let's take one more question, and then we're going to transition to that very thing, and that is what we're doing at the local level. So this question, whoever asked this question, is an interesting one because as I go out and give speeches about JPS and what we're doing, I was at a function not long ago, and while I was speaking, I was talking, the question came up, what about a bond package for JPS? And I talked about the volume increases and what we're dealing with, and the last time that we had a bond election for JPS was in 1985, and what a need there is for that. And I then went into the fact that I strongly believe that everybody that comes through our front door should have the ability to have a private room. And the person in the back raised their hand and said, I don't really think we ought to be debating whether there's private rooms or not. I think we ought to be debating whether there's a JPS or not. Because I don't think we should have a public system for paying for people who don't seem to be able to or want to pay for themselves. And that was challenging for me because I'm in front of an audience of 50 people and you want to use your internal voice. And your internal voice says, I can't believe I breathe the same air you breathe and I'm riding on a highway with you. Because that's not the way we as caring, loving people should deal with people in our society. And we should make a caste system by saying, I got a luckier straw pull than you did at the beginning, so therefore I have these and you don't, so tough on you. And I think that's sad, and I don't think that's a good approach. So it's not about whether we want a bigger building and we're prettier and we're going to compete with others. It's a matter of providing the needed services to everybody. Everybody, no matter who they are or what they look like. And as I've said many times, and I hope y'all will say it, is when the doors of the emergency room swing open, we don't pause for a second and take a time out and say, wait a second, are you a Democrat or are you a Republican? Are you part of the Tea Party? Have you paid? Have you not paid? How are you? Are you a good person at home? Are you a bad person? We just say, you're bleeding and our goal is to keep you alive. Or we want to create a 40-year partnership with you from a behavioral health standpoint and keep you on some type of an assistant medical program by which you can wake up in the morning and you can go through your day and hopefully you won't take your life, and you can be a contribution to those that love you and to this community. So this is an interesting question. So deal with the aspects of what you think about this.
So a couple of thoughts on this. First, some people, this didn't start with the Tea Party folks. This issue goes back 30 years or more, and this argument that we don't need public hospitals. My first job, the way I got into doing all this, was I was counsel for the National Association of Public Hospitals, NAPH. Not call that anymore, but I visited public hospitals in every state where they exist, and I've visited hospitals in states where there are no public hospitals, and I've looked at the differences of those systems. And I've been involved, unfortunately, in one case where the public hospital, where the folks who said we don't need a public hospital won that debate. St. Louis Regional Medical Center doesn't exist anymore because of this kind of battle. Now, here's the interesting part to me of the dynamics of this. And I'll use St. Louis Regional as an example. St. Louis Regional was about 1.5 miles from Barnes Jewish Christian Medical Center. They needed a couple more religions in their name, but other than that, they were pretty comprehensive. And that's where most of the paying patients went. And bluntly speaking, that's not where people of color went. People of color went to St. Louis Regional Medical Center. And Barnes Jewish Christian wanted St. Louis Regional Medical Center to exist, but to not be successful, not be too successful. Why? Because they wanted those people at St. Louis Regional, and they wanted those people not to be at Barnes Jewish Christian. Another part of the community said, look at how much money we are spending in local subsidies to St. Louis Regional. We could take that money, we could then create essentially a voucher program. We could give those vouchers to people. They could go to all the private hospitals. We have enough capacity here in St. Louis to treat all those folks. And so there is a pitched battle over this. Initially, neither side had the ability to win this battle. And so they did not implement a voucher program. They instead downsized St. Louis Regional, making it a large ER with just enough observation beds or overnight beds that it qualified as a hospital under the state code, so it could still get those dish monies that we were talking about before. The problem with that approach is that now there is no cross-subsidization possible with St. Louis Regional, and the pressure on the local resources is even greater. The level of acuity increases. The difficulty of providing services is heightened. The willingness of doctors to practice there goes down because it's not a very nice place to work anymore. And eventually, St. Louis Regional is shuttered and closed, and this privatization model is implemented. But guess what? There wasn't enough money from St. Louis Regional to subsidize the privatization in the other facilities. And so there were only two options. Come up with more local money to subsidize everybody else, or reduce access to care, lessen the access to care of the former patient population going to St. Louis Regional. Guess which option was chosen. And so I have been in plenty of states where there is no public hospital. What I have learned in those places, in those states, is that, yeah, they get care, but they often don't get the same kind of care or the kind of culturally sensitive care that they are going to get at a public hospital. So I'm showing you my stripe. I am a supporter, I am a fan of public hospitals. I think that there is a need for them in the marketplace, and there's a need for them not just to be successful enough to keep the private hospitals from having to do their part in seeing these patients. There's a need for them to be the true goal setters for the industry.
Let's talk a little bit about that, and let's think about where we currently are. And this is no disrespect to our not-for-profit colleagues or our private colleagues. I have a huge respect for the leadership and the folks that work at HCA, and THR, and Baylor, and Methodist. We are blessed in Tarrant County with an awfully good healthcare delivery system. But we are put at JPS in a difficult position oftentimes. And Mike and I have fought battles down in Austin.
Not against each other.
Not against each other, no, we have not. We have fought them against those forces that look upon JPS and go, well, you guys have it easy. You're the easy world of JPS because you're guaranteed tax dollars. So therefore, you don't have to be competitively good, or you don't have to be this, you don't have to be that. They don't ever seem to understand that that's a mere 40% of our budget. It's not 100% of our budget. And the challenge is we have a very difficult time at dealing with volume because we can't control it one way or the other. If our economy takes a downturn in the next 6 months, we will significantly feel an increase in the number of people that come through our front door, and we will see a decrease in that tax dollar. So our colleagues oftentimes want us to be good enough to take care of the patients they don't want and not good enough to take the patients they do want. And that is our challenge. The previous administration here at JPS took the attitude is, we're going to boldly go out there and kick them in the teeth, and we're going to start private initiatives to get private patients. And that was a failed experiment. That did not go well. That's why they bought the Arlington facility. The Arlington facility's genesis was to purchase that building in Arlington. They bought it from the Hunt brothers, which is, if you know anything about the Hunt brothers, you don't want to buy anything from them because they never sell anything they need. So that's never a good idea. And then they had an agreement, supposedly, with a private group of physicians in Arlington that were going to bring all their private patients to that facility, and JPS would make bukus of money. One, that's not our mission. Two, that never worked out. And three, it's been a struggle for us ever since trying to figure out the role and the direction of the facility in Arlington, because it is not located anywhere near our patient base in a community that has no transportation. So it is constantly a challenge. In fact, a little over 60% of those that go and get care at our Arlington facility have a Fort Worth zip code. So it's challenging. So we need to figure out what role we play and how we do that. And part of our answer, I think, is we've got to look at revenue diversity. We do need to make sure that we keep up the approach of what you all have done to raise JPS. We can be a facility of choice. We don't have to put that on billboards. We don't have to go tell Plaza, we're here to steal your patients. We can offer the best care and do really well and feel good about taking care of everybody, whether, quite frankly, they are under the Allen Street Bridge right now or where they're the individual that just bought their 5th Tesla. I don't really care. It's the ability to do that. And if we enhance that, we can keep the mission very, very strong. Because, as again, coined by folks other than I, no money, no mission. And if we don't have that, so it's not that we want to pretend we're a private hospital. We're proud of who we are. But at the same time, it's not very proudful when you can't take care of folks coming through your front door. And if we don't have a diversity of our revenue stream, it's going to be really challenging. So, Mike, explain a little bit to everybody here some of the reimbursement dollars that we provide our private hospital and not-for-profit hospital friends in town.
Yeah, you are the banker of choice here in the Fort Worth area. So I mentioned these payment streams before, DISH and UC. JPS gets those dollars, but private hospitals in the Fort Worth area get those dollars as well. However, those private hospitals need JPS in order to get that reimbursement, because those dollars are financed not by state general revenue funds, not by dollars in Austin, but by dollars coming from this community. I'll give you another acronym, IGTs, intergovernmental transfers, JPS.
Really good at cocktail parties. Remember that one?
Yeah, that's a good one.
Go to a cocktail party and say, I have an IGT. See if you get invited back to that one.
So the way these programs are funded is by JPS as a governmental entity taking dollars and sending them to Austin. Those dollars in Austin are then magically matched with federal dollars. They come back to Austin, and then they get distributed to the hospitals that are eligible under those two payment streams. JPS, as a governmental entity, can fund itself. It can send up its own revenue to Austin, and it can qualify then for those payments. That's it. Private hospitals can't. Private hospitals are not governmental, so they can't intergovernmentally transfer. They need a partner to go do that for them. JPS is that partner. And so those hospitals now, the arrangement has differed in the past, but now they will pay a local fee that will be collected by JPS. JPS will collect and put all those monies together, send those to Austin. Those hospitals will then get those payments. No transfer by JPS, no hospital payments to those facilities. And so there is, and this is where I was going with those earlier comments, there is an opportunity now, because you already have a collaboration with those folks. Right now it's just monetary, but there is a collaboration. I think that there's an opportunity for that collaboration to be more, and that we are not just always fighting a zero-sum game with them.
It was interesting. Yesterday we gave a tour to some leaders in Tarrant County, about 15 of them that we took through our main campus here. And one of the gentlemen came up to me after the tour and he said, wow, he said, this is an impressive place. I'm so impressed. And he said, I'm impressed with everybody in the hallway. Everybody's happy. They're high-fiving each other. They're saying hello. He said, I must have had 15 people say hello to me today. And I said, well, great. That's what we pride ourselves on here. We provide great care, and we're great people doing it. And he said, you know, I used to be on the Presbyterian board in Dallas. And he said, we gave a lot of money to Parkland through our foundation. He said, do your area hospitals do that? And I said, no, they don't, which is a shame. And I think we need to communicate to our colleagues the importance of who we are, and not for them to take us for granted, and not to be ashamed to tell them the vital role that we play. I mentioned earlier, Mike and I have dealt with a lot of battles in Austin. I don't go in battle as a partnership in Washington because I don't want to fly there. So it was interesting. We were in Austin and we were fighting this great and wonderful battle that we thought we had an incredible amount of opportunity to win, and we ultimately lost, as we did almost every one of our battles, but we are good fighters. And so Mike, we knew each other decently well, but at the time not as well as we know each other today. And so he said that he was going to fly back to Dallas-Fort Worth, get a connecting flight, and fly home to D.C. And I, in my efforts to discourage the Wright brothers and their idiotic invention, I said, why don't you just drive back with me? I'm going back. I've got the pickup truck. We'll get a six-pack and go on. And no, it's the rural part of me coming out. We did not get a six-pack of anything. But what was interesting is Mike said, okay, well, geez, I can fly back. It's easy. I said, no, give us some time to talk. It'll be great. And he said, I really do like flying better. It's much safer. And I said, it's not safer. Driving is much safer. And I have the statistics to prove it. And of course, he said, what are they? And I said, just get in the truck and let's go. So we headed up the highway on beautiful I-35 on our way back, and we got to Pflugerville, Texas. And we were driving through the beautiful community of Pflugerville, and the semi-truck in front of us blew a tire. And the tire just tore apart and flew back and started hitting the windshield of my truck. he is a big baby. I started grabbing things. He was dodging things. I said, well, first of all, you have a windshield in front of you, and quit being a baby. And he looked at me and he said, why don't you get on a plane with me? And I said,
No, I said, why don't you stop and drop me at an airport?
That's right. He wanted to go, not familiar with Texas geography, he wanted to go to the airport in Pflugerville and head out on the Pflugerville Express back to D.C. So he's a grand individual and helpful to us. In fact, you might be interesting, because I'm not sure that folks in the audience know, you've been affiliated with JPS a lot longer than you and I have known each other. When did you first become involved with JPS?
1991.
Wow. That's really interesting.
I was working with JPS when we created the disproportionate share hospital program for Texas, and so all the other stuff, the waiver and UC and all. Yeah, I've been here for a long time.
I'm convinced that
I was only 12 when I started doing that.
I'm convinced that Mike is truly one of the national experts, but I think he's been of significant benefit to JPS and what we do, because we need to figure out how to maximize those dollars. And what Mike and I have had a lot of discussion about is we can't keep going back to Washington and Austin and just saying, give us more. Because one, that's limited, and the philosophy is limited on wanting to do that. So it's much more challenging. JR, why don't you, is JR back there, why don't we put up the next question? All right. First of all, before we get your opinion of the Cadillacs, tell us what the Cadillac tax is, and what do you think about employer mandates?
Okay, so the Cadillac tax is an increased amount paid under the ACA for these very luxurious, that's what they're described as, luxurious insurance products. And so if you have an insurance product that covers everything, if a firm offers that kind of product, then they have to pay an additional fee to the federal government for that, which is used to subsidize the other insurance. I've mentioned the subsidies before under the exchanges. They're used to subsidize that. Employers hate it. And they want it to go away, and they are having some success in making sure it does go away. That's actually related to the second piece of this. These kind of requirements under the ACA were designed to try to make the insurance market operate more efficiently, so that there is cost-effective insurance for a whole range of people. And one of the main problems with this kind of employer-based private sector kind of insurance approach to healthcare, to coverage, is that some people won't buy insurance. The young, it's usually those who are under 35, say, look, I'm healthy. Nothing's going to happen to me. I can afford not to have insurance. I don't need to waste that money every month on an insurance premium. And so I'm just going to go without. But what does that do? It means that the risk pool is more negative for insurance companies. Insurance it's a big cross-subsidy deal. You have healthy people join the insurance pool. They are paying in, they're not receiving services. You've got sicker people there who are not paying as much as the services they are receiving, and we cross-subsidize from one group to the other. And the theory behind insurance working that way is that one day everybody is going to be older and sicker and need services, and so you pay early when you need less services, but you receive when you get older and need more services. It's an intergenerational kind of transfer, but if everybody stays in the risk pool throughout their lifetime, it all evens up more or less. With the employer mandate was designed to make sure those younger, healthier people buy insurance and are in the insurance pool, so that, again, that cross-subsidization is working. A lot of folks hated it. It looks like government intrusion into your life. If you're a good libertarian, why would you support that? I don't want government telling me that I need insurance. I'll buy it if I decide I need it. The employer mandate has been repealed under the recent legislation. didn't really matter, to tell you the truth, because the administration had already said they were not going to enforce the mandate and were not going to fine those who did not buy insurance. And so practically speaking, the mandate had already gone away. Now what we get to see is whether the insurance market is going to work with that kind of, without that kind of mechanism. Do we have the risk pools grow sicker? Do we have a mass exodus of individuals from the pool? And so as you're listening to reports in the press about the death spiral of the exchanges and the death spiral of insurance, that's what they're referring to. Does the exodus of those people mean that now the pools are no longer stable? And if insurance companies, they're making rational decisions. If their risk pool turns overly sickly and their outlays are greater than the income, they're going to attempt to quit covering people. And you're seeing some of that in individual markets where they're leaving those markets.
Let's shift gears for a second and talk a minute about something that has obviously a lack of clarity to it, and that's the future. And let me, before, Mike, we go to some of your comments about what you think from an individual that sees the nation as a whole and Texas and where we at JPS are going. Let me make a few comments about where we should be entertaining thoughts of where our future is and where it lies. I think what we are going to look at in the future, and the future being a year from now and the future being 10 years from now, is we've got to figure out the role and the efforts that Karen Duncan and Joy Parker and Dustin and the others are doing from the standpoint of keeping our community clinics and the primary care aspects vibrant and strong. Because you can't build $50 million new EDs every other month. And that is an answer on paper. Let's just build more EDs. But that is an impractical approach. So how does JPS, with a structure that we have in place, but yet needs for greater efficiency, create a better community clinic system to decompress that emergency department the best way so that we have an emergency room that is manageable, not an emergency room that is unmanageable. Then I think we look at the success of a claim and what we do with the claim and how we get not only the engagement of our physicians, but how we do managed care contracts and what we're looking at and how we begin to leverage a claim to the benefit of our patients as we go forward. And the new initiatives that we're creating through a claim and trying to figure out how to do that. I mentioned earlier, revenue diversity. We've got to think, I think, Sharon, in the last 2 years, we've lost roughly $14 million from the federal government by the stroke and a change of formula funding. And we have no recourse on that. In fact, the timing on those have been horrible because in each case, it was 2 weeks to a week after we passed our budget. And the federal government said, oh, by the way, you get $10 million less this year, you get $4 million less this year, and we have no recourse. So the only recourse we have is to look at public-private ventures, potentially, looking at the development of the land that we currently have, land that we have that fronts Magnolia, where we park cars on, that might be a better use if we had mixed-use development there through a joint venture. And we looked at having some form of a profit share for JPS to help offset that, looking at putting smart things into place that would help us. The other thing I think that's critical for us in the future is trying to deal with our technology issues. When we just got done with Joint Commission, the Joint Commission review this time was significantly different than the Joint Commission review of the past 3 years, because now it was all about ligatory risk and safety and where we were. My prediction, and I could be way off base, is I think that the next Joint Commission review in 3 to 4 to 6 years is going to be looking at technology risk in the standpoint of your data collection bases and what you're doing in addressing ransomware and what you're doing with the security of your system. Because if you're a bad guy out there, we make bankers and Walmart and American Express look like pikers in a minor league ball club, because we collect so much more data on so many more people. With one swipe of one healthcare organization, you can put all the rest of that to shame. So I think they're going to come in and say, where are you with security on your technology? And then I think what we need to do is continue to grow our reputation. Continue to have that outlook that we had from 20 people that took a tour of JPS yesterday that walked out of here and said, wow, this is an incredible place. So Mike, tell me about your view of the future, things you want to pose to us. You know, your professorial side will probably come out in this proportion. So
yeah, I think I'll start with that. So let me get you involved. I don't believe.
Now they're not making eye contact with you.
Yeah,
Everybody
no, I'm used to that with
looking at you.
students. Don't make me walk around here, because I will, and I'll call on you. Let me start with a question for you, and then I'll ask you one more, and we'll talk a bit about the future and what it holds. Think for a moment about how long you've been doing this for a living. What do you think is the one thing that has had the most profound effects, brought the most profound change to the delivery of medicine since you've been doing this?
And we'd like to capture this. We're actually videotaping this, so if you could wait to speak into the microphone so we can get it on video.
What do you think?
And since we are videotaping it, if any of you would like to stand up when you ask your question or answer it and break into song or dance, that's okay, because it's videoed. Joy, our first dancer, please.
She has like two.
As an almost millennial, I would say, I'm on the cusp. I would say our technology, and I think the things that we talk about in community health about how we are promoting access is how are we expanding access to healthcare outside of just buildings, mortar walls, is really educating the patient and using technology. We see this coming, iPhone, telehealth, telemedicine, and it's kind of interesting, the evolution of healthcare is actually going back to its origination, in my sense, is it's going back to the home. So for me, that's what is on the forefront of my mind, is how do we leverage that and use that to help keep our costs down for our patients.
Okay, so in terms of your thinking about technology, the technology you're referring to are those personal devices, those things that give a person the ability to control and affect their health.
Right. I mean, I think that's an element of technology. I think you see social media. I mean, there's all kinds of, a lot of the solutions that we're looking at for interventions in order for us to get disrupt dollars pertain to things like Outcome Health and ME Solutions and these companies that are helping to promote and support health education to empower that individual to actually take control of their health. I think the other person is my co-partner, Tina Picklesheimer, wherever she is in case management. I think that is really going to have a profound impact, is how do we actually bring this true case management to the forefront and really manage the entire patient. So that's my...
Great, thank you.
Yeah.
Thank you. Other ideas?
Laura, right behind you in a minute. Oh,
Good morning, sir. Thank you so much for being here today.
Thank you.
I think the most profound change that I have seen through my 20-year career is the increase in publicly reported data. I know that you alluded to outcomes data previously, and looking at value-based care. From my experience, today we talk about Leapfrog Hospital Safety Survey, we talk about Hospital Compare, we talk about health grades, and we're putting more power to our consumers to be able to choose the hospital of their choice, and JPS being at the cusp of being one of those hospitals, if not the hospital, for people who can afford insurance or for those who cannot afford insurance.
Terrific.
So two things.
I think we can't forget about our physicians, because in all of this, suddenly they had to start working harder and doing more too. So the way we partner with them has changed significantly. We say HTD where I work because it's helped the doctor. We have to figure out how to be efficient also so that we can help them do the work they need to do. Second thing is the electronic health record. We got paid to put that into production, and we haven't utilized it the way we should yet. So we've got a lot of work to still do on that, I believe.
Good. Thank you. Stacy?
I think technology is something, as we've all looked at it, and I think we also do have to look at technology and how we manage that in patient safety, because I think along with great data collection and other things, as we put electronics in procedural areas and more equipment and more technology, it can also, I think, is what is leading to a common struggle among all hospitals in patient safety, because now we have everybody focused on screens and on things, and it can take away from patient care and patient safety. And I think it is vitally important that we look at how technology affects care at the bedside and in procedural areas and direct patient care. And I think that's everybody, I like technology too and everything it can offer, but I think we also need to be very careful in how we manage it and use it. And I think as a healthcare, as an industry, we haven't quite gotten there yet.
We as a society haven't gotten there yet. If you look at Facebook and the data stripping that's gone on, I think we should all be very nervous about that.
Yeah, to tie on the technology in with the metrics, I think we're on the precipice of finally being able to move from healthcare or sick care to actual healthcare. You know, we have these great initiatives with Healthy People 2020, but are we actually able to meet them? So can we finally use all this information and use these preventative task force for what they're intended for versus having to wait until our patients are so sick that we can't actually help them?
These are smart people.
They really are.
They really are.
You weren't kidding.
Done, yeah.
Thank you for being here. This is my 18th year here, and technology definitely has changed everything from, the first time we looked at the Da Vinci machines to where we are now with electronic medical record, and there's always improvement. But the greatest change for me has probably been this culture that we have in this room. And for me, when I first got here, I looked forward to really being part of a true team. And that teamwork didn't start until probably about 8 years ago. It was a place where people came to work, they did their job, and then they went home and they forgot about JPS. And what I see, there's a pride in this group, and there's a camaraderie that we have in terms of healthcare, that we really care about what we do in terms of the services we provide. It used to be we just provided the service. Walk in, get it, all right, next. And I think that, for me, has been the biggest change, and that's what drives us to look for the new solutions, drives us to look for the better healthcare. It's what drives us to become number one. For me, it's that change in the culture that has evolved to include now the leaders in this room.
That's terrific. So we had a bunch of folks talking about technology. We end on what I think may be an even more important point about the cultural aspect of delivering care. You can have the best technology in the world, and if that's all you're doing, if you don't care about the patient, if that's not your end goal, if your end goal is not total health for the patient, then you're wasting the technology. My view is that technology is going to drive a revolution in medicine in the next 10 to 20 years, and it is going to be profound. It is going to be unlike anything that I've seen in my lifetime. And per your question about the data, it's going to be a bit scary as well, and we're going to have to figure that out. One, I think medicine is going to become much more individualized. Now, we think of disease as affecting all people, and doctors, you can correct me at any point here if you disagree, but we tend to think of them as affecting a range of people in the same way. We're going to begin to learn, we're already learning, physicians are figuring this out, about how different diseases, how a disease affects differing persons, which allows then for a personalization of the drug or the treatment that's involved. Now, instead of Robert just getting a statin drug, he's going to get a Robert statin drug. It's going to be specialized to his own particular circumstances. Second piece of this, we've decoded the genome. That's going to allow a whole range of medical interventions that were not possible before, and is going to drive us toward the delivery of and the protection of health, not just the treatment of sickness. I think we have the opportunity now to suddenly, maybe finally, start delivering health care, not sick care. And then we've got nanotechnology, where we're going to put small things inside the body. Those are going to either affect the medical condition and treat that internally, or relay back data and information to a caregiver who can monitor that 24/7, and again, further that kind of specialization. And that's on the treatment side. In terms of the way we deliver care, big data is going to change that as well. And you're right, we haven't figured out yet how to take advantage of the data that we have. Medical records, we're still really in the infancy about how to make that work. There's no interface with other providers here in this network. Ideally, and part of this is problematic because of the model we have in this country regarding the ownership of data. Right now, your data is not your data. Your data is owned or controlled by someone else who attempts to monetize that to make gains. My view is that a key part of where we need to go in healthcare is to change our paradigm with respect to data. Your data should be your data, that you have, that you control, that you can share, and that you are given the tools of interfacing that data with various providers. But that's going to take a sea change in the way we think about this, and a change outside of just the medical environment. And then a final point with respect to that individualization of medicine. My sense is that we are flattening the traditional pyramid of care. We've had this notion that, depending on how you view the pyramid, patients are either the top or the bottom of the pyramid, and they are not the ones ultimately responsible for health. I think we will have already begun to flatten that pyramid so that promoting health becomes a partnership between the patient and the care provider, and the patients are going to be given the tools to use to better help themselves promote their own health. I mean, I've got my Fitbit on at the moment. It's beeped at me twice already, telling me I need to get up and move around. And this is a pretty primitive device. And so I see in the future where you'll have devices that'll tell you a whole lot more about yourself and about the world you live in, and how to interface and promote your own health. So I am very optimistic about the change that's going to come to the delivery of medicine because of the technology that's there. I'm a little scared about the data that's going to generate and how we protect that data, and that is not ultimately used against us. And then I'm also, quite frankly, a little pessimistic about the ability of our politics and our policy to keep up with these changes. Politics is a lagging institution. It doesn't usually set the stage for what is to come. It reacts to what has already happened, and often it reacts too slowly to what has happened here. And so how do we get our politics to catch up with the other changes that are going on? I think that may be one of the biggest challenges we have here.
I think y'all's answers to Mike's question about what you've seen were really powerful, because if you look at it, if you listen to what Joy had to say, that the technology aspects have made such a difference in our life. I mean, we weren't even talking electronic medical record 10 years ago. You just look at the changes JPS has seen in that time period. They've been pretty phenomenal. I think how you use that technology is going to be really critical to Stacy's point, and that is, how do you use that data for the benefit of those who work here and those who deliver health care to our patient base and not let that technology direct us or guide us, but help us and be a partner in the healthcare delivery. Because it was interesting, I was walking down the hall yesterday and there was one of our employees, and we all do this, on her cell phone. And she was just clickety, click, 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 click. And so I stopped. And I stopped 20 feet ahead of her, and she walked right into me. And she said, I'm so sorry, I'm so sorry. I said, that's my means by which you have to say hello to me. And they can become all-encompassing, and we got to put technology in its place. To Dr. Potowitz's point of the cultural changes at JPS, that's y'all. That's an organization that said, we don't want to be the organization we have historically been. We don't want to strive for mediocre. We want to strive for better. Whatever moniker you want to give us in the community, we will prove who we are and the value that we bring to this community. So that cultural change has become so powerful at JPS because that's who you are now. That's what you are now. Those who don't want to follow those 3 rules and be a part of that cultural change have now become outliers, where I would argue before we had more of that as a normalcy. And it's not to say anybody here was just wretchedly bad. That's not it. It was just that was an expected practice. I remember one time that the state of Texas was changing its requirements in its public school systems from a failing grade from being 60 to 70. And a very smart school and superintendent told me, you set the expectations for children and they will attempt to meet those expectations. So if you want your failing grade to be this, they'll shoot for that. If you want your failing grade to be here and raise it, they'll shoot for that. What we did at JPS, in my opinion, was not say, you know what, all those 110 plus years you've been in existence, you've been horrible until we got here. That wasn't the case. We just set our standards higher, and a lot of people wanted to meet those standards then. We have different expectations for who we are and what kind of health care we deliver. And when we don't deliver that, it becomes the outlier by which we all look and say, we don't want to be that. We don't want to do that. We weren't asking those questions.
And Robert, per my comments earlier about St. Louis Regional, and I can really pick on them now because they don't exist anymore, but a major problem they had at that institution was this issue of the culture there. There was not pride in the institution. There was not pride about delivery of care. It was a bad place to work, and people did not really want to work there. And you can have all the money in the world, and that will help, and you have new technology, but if you don't remember why you're doing that, then ultimately the institution is not going to be successful. One final point with respect to this, and that is thinking about the JPS of the future and what do you look like now 20 or 30 years from now. The difficulty of prediction, predicting is really hard, especially if it's about the future. And we don't know what we don't know, right? So I remember being in a smart home in the mid-1980s. And it was wonderful because you could control all these various things. You could hit a button on the wall and the fireplace came on. And everyone thought this was wonderful. And the design was built on running wires everywhere behind the wall, connecting all these various devices. Is that the way a smart home works today? This was before PCs. This was before wireless and Bluetooth. Now, that's a dinosaur approach. And so trying to think through this technology and not just think incrementally, but think about what JPS is going to be in 20 years, we have to think beyond the current paradigm. We need to think, I believe, about what a more individualized approach to health looks like, and how does a hospital in 2050 or 2040, what does JPS look like to promote that?
Well, I think the key to that and the key to our future is being nimble. We cannot be resistant to all change, and we cannot just jump off the cliff of change for the sake of change. We have to be nimble and smart about what is to confront us, because I'm not sure what it is, but I apologize for the bad analogy, but it's more like being an outfielder. You got a glove, and you're going to try to figure out where that ball's going, and you run to catch it. But you don't stand in the outfield without a glove, and you don't stand with your back to the batter. It's not going to work. So we have to figure out how we're prepared and what we do, and I think that's it. I also want to tell you all, just to Dr. Podlewitz's point, just how proud it is to be with you all. Just how proud it is to have an LDI like this, where we have such interested, concerned employees that want to ask questions, and I apologize for the questions we didn't get to, but I appreciate the fact that you're here, and we want to learn, and we want to gain. I think you've seen what an incredible place this is, and I have to apologize to you, because we brought Mike in 6 months ago to take a tour of JPS, and since 1991, it's the first time he ever got a tour of JPS. And so I apologize that people before had not given you the time to understand who we are, but I'm also thankful that you got to see these beautiful faces and these minds, because this is who JPS is. I know, and I bet, because I know you well enough, that there is some form of a homework assignment that you're going to want to give. I just know you well enough. So get it out of the way and let them then now dislike you, because I think they're liking you. So let's go from there.
Yeah, I got to give you homework, but I hope it's fun homework. The first part is short. The next part a little longer. We're gonna, and I'm not sure exactly how we're gonna distribute this, but we've talked about a lot of topics today. I'm gonna give you a reading list. I'm gonna give you some things to read over the summer when you're at the beach on some of the topics that we have talked about today. And if you want to know more about any of those topics, then don't hesitate to contact the right folks, and they'll get you in touch with me, and we can follow up and chat more. The second part of your homework is right now. So you've got these cards, and on one of the cards, I would like for you to answer this question. Our goal is to not make this just a one-time event, but rather the start of a conversation. I believe in crowdsourcing. I think that knowledge is better and broader if a lot of minds are brought to a task. And so I want your help in trying to predict the future and what it looks like. But also, I want your ideas about how we can go impact that future and bring about the future that we want. My view is that big change is really tough, and no one of us is going to go change the health delivery system or the reimbursement system or make the insurance markets different. That is above my pay grade, and any impact I have is going to be very small. But I've discovered I can have an impact closer to home in the things that I can relate to, that I can then affect. And so I'd like for you to answer this question. What can you do in the next year to go impact the delivery of care here at JPS, keeping in mind those visions of the future, but not just at JPS, here in the Fort Worth area as well. And we're going to collect all these, and we're going to synthesize them, and that's going to be the basis of a future conversation on this topic.
Laura, do you or Pia want to close us out so that we can all go to the rest of our days and continue to help patients?
Absolutely. Was that good? Yeah? Thank you so much. Once again, right? So here's how our homework is going to work from today to the next LDI, which is June 29th. So if it's not on your calendar, go ahead and check that and mark your calendar. We'll be back at the Hearst Conference Center on June 29th. Between now and then, we are asking all of you to participate in some homework. And an email will be sent on Monday describing all the details of it. So please check your email as soon as possible so that you can get started. And it's actually really, I think you'll find it very exciting and very interesting as you start to learn from each other and continue this conversation, because the way I view today is really the start of a conversation that takes us through the rest of this year. And so our LDI in June and the one in September will piggyback on this. So we want to be sure that you have a full understanding of this particular content and at least the concepts of this at even a basic level to be able to make sure that we're hitting the mark as we go forward. So watch your email Monday. It will come from the regular administration email sender as normal, but there's a lot of details in there, so please read it thoroughly and let us know if you have any questions. You can contact Pia or I individually, and we'll be happy to answer anything for you. Thank you. Thank you. And thank you all for coming.